Dr. James Helliwell is the president of the BC Anesthesiologists Society. He is an echocardiographer. Yes, I'll say it, echocardiographer, clinical instructor at St. Paul's Hospital, and he is one of the highly trained anesthesiologists you hope is in the ER if you need a new hip, a new heart, or other procedure. It is my pleasure to welcome Dr. James Helliwell to Studio 4 to tell us more. Nice to see you. Nice to see you. Thank you very much for having me. It's a pleasure to be here. I'm so happy I get to say anesthesiology on a Monday morning.
That's right. We like the tongue twisters first thing.
Yes, the anesthetist, and he is the president of the Anesthesiology Society of BC.
That's right.
Mm-hmm. So, tell me about the training. So, to become an anesthesiologist, med school, and obvious, then what?
So after medical school, you then have another 5 years. In that 5 years, you go through an intensive program where you learn critical care, you learn all about the brain, the heart, the lungs, you learn cardiology, and then you also spend a lot of time anesthetizing patients, obviously, and you have to deal with every kind of patient. And that's the thing with anesthesiology is it's not one kind of patient. You have to be expert in any disease. Because you will see every patient from young and healthy to old with 15 different problems. And so that 5 years we focus in on all of that. And then at the very end you have to go through a rigorous 3 days of examinations and get through those examinations. And then you can then go and work. If you want to work in a teaching hospital, you then need a further 1 or 2 years of training to subspecialize in something like what I do, which is cardiac anesthesiology for heart surgery, heart transplantation, and things like that.
So residency, after you go med school, then you, the 5 years.
5 years.
And residency?
Yep, so the residency is the 5 years, then you do your examinations, and that gets you your designation as a specialist, or FRCP, so Fellow of the Royal College. And then you can also go on and do further subspecialty training in things like neuroanesthesia, obstetrical anesthesia, cardiac anesthesia.
That's rigorous.
So it's a long time, yeah. Most people
and
don't
dedicated.
It takes a lot of dedication, both on the part of the anesthesiologist as well as on the part of their family to support them through all of that. And you know, you're really, by the time you actually hit the ground, pretty much the youngest you can be is 32 or 33.
I would think.
Before you're actually able to work your first day.
Do you remember your first day? First time you were alone, in charge?
I do remember my first day alone and in charge. I was doing a cardiac procedure, and it was exhilarating and kind of scary as well.
I'm sure.
Because you have a lot of responsibility on a moment-to-moment basis. And
so inside the operating room,
yeah.
Tell me about the pecking order.
Yeah.
Obviously there's a surgeon,
yeah.
generally,
Yep.
and a nurse,
yep.
or two.
Or more.
Or more.
Yeah.
And an anesthesiologist, just one?
Just one, occasionally two. So in some complex, large procedures like a heart transplant, there will require two of us for periods of time. Most of the time we make do with one. We also have anesthesia assistants, not a lot of them, but we do have them around for some of our more complicated rooms, and they help us set up various things that we need to do and do some of the procedures that we need to do. In the pecking order, I would really say we work as a team. So surgeons, nurses, anesthetic assistants, anesthesiologists, we have to work together, and we all have the one thing in mind, which is the patient. And we each have a very different job. Our job is to not just get the patient to sleep, which is what we always talk to the patients about, but really what that means is actually controlling their brain function, their heart function, their lung function, and doing all of those things for them throughout the duration of the surgery, and to create an environment for the surgeon to be able to do what they need to do.
So in a sense, you monitor what's going on. You keep us alive while the surgeon is working his or her magic.
That's right. Yeah.
What type of anesthesia is available today? What types? Like, how do you determine, okay, you're having a heart transplant, you need this. Yeah. You're having a hip replacement, you need that. Yeah. This will knock you out sooner. Yeah. This will keep you out longer. Yeah. How does that work? Well,
we have a complex decision-making process, which is part of what that 5 years of training was really all about. And so every anesthetic is different. So every anesthetic is tailored to the patient, to what is wrong with them, and also for the surgery. And whether it's an emergency, whether it's an elective surgery. And so we have a variety of options that we can do. So under general anesthesia, there's hundreds of different ways of delivering that in a safe way, whether you have heart disease, kidney disease, brain disease. And so we need to deal with all of those different things and to create essentially a recipe that's unique to that patient. And then we monitor that throughout. We monitor the heart, the lungs, the brain, and we look at all of those things. And we tailor the anesthetic throughout, kind of like flying a plane. You can't take your eyes off the monitor for 2 or 3 minutes, because if you do, things can change quite quickly.
Sure, and if something does change quickly,
yes,
heart rate drops,
yeah,
a lung function isn't good, then what happens?
So, and that's really where the first thing we do is try and see it before it really becomes a problem. And that's where vigilance, which is one of the things that we really try and teach and is part of the mandate of our training, is to teach people to be able to spot problems when they're very small before they become big problems. And if there is a problem, that's our job, is to deal with that, to rectify the problem as quickly as we can, and communicate with the rest of the team as to what we need. Occasionally we need the surgeon to change what they're doing, to do something differently, to make it a little bit safer for the patient.
And how do you know, as the anesthesiologist, if someone is out, ready?
Yeah, so there's a variety of things that we have to do that. We can actually measure the brain waves. So we actually have monitors that measure your brain waves like an EEG. So we can see the level of brain activity. We also look at the heart, the lungs, the heart rate, things like that. And they all will tell us whether or not you're asleep. And we have a variety of things that we're trying to do. It's not just have you asleep, it's have you comfortable, have you not remember, have you, be able to cover the broad spectrum of what the patient needs for their comfort as well as for their safety.
And have you had some weird stories, some weird after stories about what people went through? Has anybody ever said to you, you thought I was out, Dr. Helliwell, but I wasn't? Yeah.
I've never had that. In fact, it's incredibly rare.
You see it in the movies.
You see it in the movies. It's incredibly rare. People do have awareness under anesthesia, but it's in the 1 in several million, and it tends to be confined to emergency surgeries, so emergency trauma surgeries, in the kinds of cases where really it's the state where if we give you much more, you'll die. And so those are the patients often who are aware. For most other patients, they don't have that. They do tell us about great dreams, though. A lot of patients have wonderful dreams.
Now, is it whether you're male or female part of the equation, the weight of the patient, all of that?
All of that has to go into it. Every single piece. If you're a diabetic, and not just if you're a diabetic, are you well controlled or poorly controlled? How far can you walk? What kind of lung disease do you have? Have you ever smoked? When did you quit? All of those things make a difference to how we can deliver the anesthetic.
And if it's elective surgery, of course, they can tell you don't eat, and they give you sort of that list.
Yes.
But if it's not emergency surgery and somebody's just come from a steak dinner, what's different?
So their stomach there is full of everything that they had at their steak dinner. And there's a high likelihood of, and what we're trying to do is to prevent that coming up and going down into the lungs, which of course causes serious complications. And so that's why we always have people fast. They say, why can't I eat after midnight? And that's why we don't want anything in the stomach. And with an emergency surgery, you have to deal with everything that's put in front of you and do what you can to mitigate the risks for the patient.
And why can't you drink much? Water, fluids? What's that about?
So the fluids you can have up until about 2 or 3 hours before. And it's exactly the same thing. We don't want whatever's in your stomach to end up in your lungs. And water gets absorbed quite quickly, usually within 2 or 3 hours. Other things, milk, get absorbed very slowly. And so that's why we need to really avoid things like that.
So once you administer the anesthesia and the patient is under and the surgeon begins, can you leave the room?
We remain in the room by the side of the patient the entire time. If we have an anesthetic assistant or a resident, so someone who's in their training for anesthesiology, we may delegate that responsibility to them for a brief period, usually not more than a few minutes. And because things can change so quickly, we need to be there. So all across Canada, you have 1 anesthesiologist per patient.
And what's the longest time a human being can be sedated? Is that the right word? Yeah,
well, so it depends on the level and what it is that you're doing, and obviously it depends on what's wrong with the patient, but I mean, we have patients asleep for several days at times, so it depends on what you're doing. And a lot of our surgeries are very long. You'll have 8, 10, 12, 14-hour surgeries, and obviously the complications can increase with time, and the implications of the drugs that you're using change.
So is it a one-shot deal? And by that I mean, like if you know somebody's going to be under for 12, 14 hours, you give them the proper amount at the beginning, or can you top it up?
Yeah, no, in fact, our anesthetic is governed minute to minute, second to second. So we're watching all those monitors we just talked about, watching all those things, and we are constantly changing the anesthetic based on what's happening to the patient, what's happening in the surgery. And that's why we don't leave. The patient's asleep, and we don't, they're not on autopilot. In that sense, it's not like flying a plane, because there is no autopilot with human beings. And it would be easier if there was, but...
Right. But imagine 50 years ago or 60 years ago or 100 years ago what it was like in the OR.
Yeah. Well,
how different it was. It must have been. Without all the monitors, I'm sure there were some monitors, but I remember the ether days.
Yeah. It was very different. I mean, you're talking about, I mean, our profession is very young. So it was the mid-1800s in Massachusetts at Harvard where the very first anesthetic was given, and it was for dental surgery. And so our profession has learned since that time. And it started initially with nurses dropping ether and chloroform and the surgeons sort of guiding things. But the mortality rates were very high. And if you look around the world where people don't have the training program that we have, the monitors that we have, and that sort of set of skills and resources, their mortality rate from anesthetic and from surgery is very high. And you know, they'll say, if you're 60 years old, we won't operate on you. Yet we do heart surgery on 90-year-olds. And the reason for that is that our anesthesiologists are well-trained, well-equipped, and there's just not enough of us.
Yes. Well, and that's a problem. When we come back from the break, we're going to talk about that, about why aren't there enough of you and what's really going on politically with anesthesiology. Dr. James Helliwell, our guest.